Hi, everyone. This is Lynn Crawford with Hope Dementia Support, and we are privileged today to have Dr. Lynda Tang, Palliative Care with the Vancouver Clinic, here with us tonight to discuss hospice and palliative care when your loved one has dementia. So I would like for you to know that you can put your questions in the Q&A or chat. We'll see that they're answered before we finish this evening. And other than that, I'm going to ask Dr. Tang to tell us a little bit about herself, and I will just disappear.
Well, I hope you don't disappear too far away.
No, I will be invisible.
Yeah. So my name is Lynda Tang. You're welcome to call me Lynda. I live in Philida, Hazeldale area of Vancouver. I moved here from the East Coast in 2015. So if you do the math, that's how long I've lived in the Pacific Northwest. I am an outpatient palliative medicine doctor at the Vancouver Clinic. My office location is on 87th Avenue, which is right across from Peace Health Southwest Hospital. My practice is purely 100% outpatient clinic based. I don't round in the hospital, don't do home visits. I would love to. I would like to think about a program such as home visits, but right now it's just me, two medical assistants, and then three nurse case managers that help take care of our patients in Clark County. Some of them come from Oregon across the way, but most of them Clark County. I guess some stragglers from Longview and up north, but not too far. And then, of course, I do telemedicine visits. Back to you, Lynn.
All right. Um, I'm going to allow you to tell us how you want to proceed here. We did get some very specific questions. And interestingly enough, in our group leader meeting this week was actually hijacked by Hospice and Palliative Care. And we spent the entire meeting talking about hospice and palliative care. So if it's okay with you, what I would like to do is to kind of ask you some of the most important questions and see if you can answer them for us. It is not a test, however. So one of the things that we hear a lot of from our support group members, but our group leaders were also asking about that clarity, was what is the difference between palliative care and hospice?
Yeah, I think that's a really good place to start. And because this question is so very popular and common, I decided that I would make a little animation that I think has worked for a lot of the patients that have come to see me. And if not their patients, definitely their families. One of my requests to do a consultation for patients having dementia, whether it's mild, moderate, or severe, is that they have a family member or a caregiver be with them at those visits. It just enhances the experience and is more useful of the time. So I'm going to share screen here. So I usually draw this on rudimentary flip chart paper in the room with Crayola markers. I draw this line and I say, this is your life. This is your age over time, and then the disease progression that you have. And for this group, it would be dementia. So over the course of a patient's lifetime, you can have many different things. You have different teams that you're on. So everybody, when they're born, they're on team blue. And that team's goal is to diagnose a disease, treat the disease, provide cure for the disease. Like that is what your primary care attending does all day long. Your heart doctor, your lung doctor, Maybe you see a geriatric doctor. And then your care is also, when appropriate, delivered at an urgent care, maybe the ER or the hospital. So this is all Team Blue. And palliative medicine is part of Team Blue. And what palliative medicine sees as a specialist is we see patients with advanced chronic disease. So your mild, moderate, severe dementia, your moderate to severe COPD, the heart failures, the cancers. So it's not stable diabetes. It's not a little bit of hypertension. Our patients have more chronic illness that is more burdensome to their quality of life. And that burden can show up as symptoms. Your dementia patients or a family member might have agitation, right? Sundowning. They may not sleep really well. They might be feeling very anxious because of their delusions or hallucinations. They might be depressed. They're not eating. Maybe they're constipated. Um, it runs all sorts of different symptoms. So I'm looking for those symptoms, and my goal as a palliative care physician is to symptom manage support those symptoms. So then the demented patients, the COPD patients, the heart failures, they can improve their quality of life, help them get through the day. And then, of course, depending on where you are in the progression of your disease, then there's going to be caregiver distress, family distress. Dementia is not a one patient disease. Your daughter, your caregiver, your son, your whoever you call family, they're going to have adjacent dementia to the patient. Just like you can have adjacent cancer, right? Your loved one has cancer, you're going to have a part of that. It's going to show up differently, but it's adjacent to. So I can help with drawing a roadmap, talking about what's been given to you in terms of information. And people need to hear things 3 times, maybe more than that, for it to stick. Um, let's say that the patient has been admitted to the hospital very frequently in the last short number of months, and that's caused a lot of burden to frailty, functional state, quality of life. Or this one hospitalization was so tragic that the patient had to go to rehab, and maybe they're still at rehab, and we don't know if they're going to come home. And if they do come home, they're not the way they were when they went into the hospital. So then we talk about their values, their quality of life. We talk about their faith, if that's appropriate. And we do some advanced care planning. Sometimes patients come into my office and the daughter, son, family member is saying, we need more help at home. It's not safe. We're wondering about what the next step is if we can't take care of our loved one at home any longer. So then we enter into the conversation of the higher level of care. That's what the HCLOC means. So this is a patient. I'm not a gatekeeper. I'm a specialist. So I receive referrals. So I don't get to control when a patient comes through my door. So it could be early in the disease. It could be very late in the disease. I just put this lovely patient right here. So over time, as disease progresses, then what you're looking at is, when do I go to Team Orange, right? You're going to be on Team Blue by default. But at some point, your disease is going to reach a place where you're looking for comfort, and your focus is on comfort. And your planning is an end of life transition. And usually that is when your disease has a less than 6 months prognosis. You're talking end stage labeling. So end stage COPD, end stage diabetes, heart failure, liver failure, cancer, even severe dementia. So this is where the hospice team comes in, right? So you are literally changing teams. You can only be on one team at a time. And so when that time occurs, anybody on your blue team can make a referral to the hospice team, which is the orange team. So maybe you have COPD and the lung doctor says you're approaching end stage. We think that you're less than 6 months, you might want to think about enrolling in hospice. So another way to look at this is who are you calling, right? Are you calling the blue team or are you calling the orange team? Because you have to be on one team. The other question is who is delivering and providing the medical care for the patient? Is it blue team or orange team? And again, you can't have both. So you have to figure out which side of the door you are on as it relates to dementia. And I would say some, it's hard to tell, but it's rare that a patient comes to see me and they only have dementia. Usually they come, they have dementia, it's getting worse. They also have diabetes. They also have heart failure. They also have other things going on. So they definitely are more sick. Questions about this schematic, the animations?
If things pop up, I will interrupt you if that's okay.
Yeah. So we can go on to the next question.
Okay. Um, it was a question about describing the way that palliative care can be offered and the way that it specifically is offered in Vancouver.
Yeah. So in Vancouver, my outpatient clinic, we discuss all this purple stuff, depending on what you need when you come in. So that's done in a clinic. I see the patient. I do telemedicine visits, so it could be over video. And again, it's usually with the patient and then a family member or 5 family members or people, caregivers, what have you. Palliative medicine can also be delivered in the hospital. So that's when a patient goes to the ER or the hospital because they aspirated, or they're having a UTI, or they had a side effect of a medication. And so their family member, caregiver brought them into the ER in the hospital. And so if things are going nicely in the hospital and it's just, a one-off, then you may not see a palliative medicine specialist at all. But if things are getting kind of touchy, they're kind of getting complicated, we're talking about CPR, talking about intubation, maybe feeding tubes, things that really require a discussion that may or may not be in the benefit of the patient, then the hospital team will make a referral to either neurology, geriatrics, PalMed, whatever it is that they need, and usually they call us in to the hospital when they feel that a family meeting needs to happen. And usually the words they say are, and no judgment to anybody, they'll say the family doesn't get it. This patient needs hospice and the family doesn't get it. I don't think they know what's going on. I think that the family is not all on the same page. One person wants the patient to go home and continue to live at home. The other family members are saying she needs to go to memory care. And then one third person says, let's send her to the ICU because we need to intubate her and do all the necessary things to save her life. So we come in and we try to set up a family meeting to say, where are we and what is in the interest of the patient. Um, in Vancouver, Peace Health Southwest, in 2015, when I arrived, they had a team of nurses that provided what they called home-based palliative medicine. And it was a team of like 3 nurses, I believe, who would get on the phone after a hospitalization of a patient, or their chart was flagged, and they would actually call the patient and the family. They might do a little goals of care. Uh, Being nurses, they can't write orders, so they couldn't do symptom management. But they could talk about trajectory of dementia, signs and symptoms, and then advanced care planning or even discussion about a higher level of care if that was appropriate. I believe that at some point from 2015 until now, they did some home visits, but again, it's nurse driven. Um, Ideally, if you have a home-based palliative medicine program, you have a physician or an APC writing orders, visiting the home, working with a team of nurses, physically being in the home or a telemedicine based practice. And so I feel that through the pandemic and the highs and lows of healthcare, I'm not 100% sure what the program at Peace Health Southwest looks like anymore. They've had different physicians come and go to try to do different priorities for the hospital, whether it was to really have a dedicated presence inpatient or outpatient or even home visits. I believe that Providence in Oregon also services Vancouver. And their program is probably bigger. And so they might also offer home visits in addition to inpatient, outpatient, and whatnot. But in order to have a really good home-based program, um, you need it set up in a nice workflow. It can't just be sloppy. And so that's why we don't have one. We don't have the manpower. We don't have enough physicians, APCs to be able to carry that out and make home visits. So luckily we do have video visits, which I think is a pretty good solution if we can't get me into the house and drive around town.
So a couple of questions popped in, and one of them is related to insurance coverage for comfort care.
Okay.
And the question is, does comfort care vary by insurance carrier?
No. So so after 65 years of age, you get Medicare, and Medicare is what pays blue or orange. Medicare is the reason why you can only be on blue or orange because the purse goes to one side or the other. So it is not dependent on if you have good insurance, bad insurance, like Medicare will pay for blue or orange. Um, Before you hit 65, I think you have to apply for Medicaid. Some of the supplemental insurance, like, will pay for hospice. The general idea is that the cost of hospice, Orange Team, is significantly less than the cost of Team Blue. And so it is in the patient, the family's spiritual, emotional, physical benefit to not have an MRI the day before you die, not have major surgery the day before you die, be getting some sort of chemotherapy the day you die, the day before you die, the last week before you die. It's not that we're pinching pennies and we don't want to like give people stuff. In America, we give people a lot of stuff. And I think where I am learning talking to families and patients in Clark County and Pacific Northwest, people are more like, stop doing stuff to me, stop getting my blood, stop requesting that I go get stuff done when none of it is helping me have better quality of life, even improving my longevity, right? Like another CT scan isn't going to tell me more about my vascular dementia. A PET scan isn't going to tell me more about my cancer when I've failed 4 trials of chemo already. But we live in a world of more. And so if you were on Team Blue and you entered the ER hospital, they're going to do more because you showed up. So they're going to get the EKG, they're going to get the X-ray, get the vial of blood, they're going to give you the workup. And I guess that's okay. if it's going to make a difference. But if it doesn't make a difference, usually my dementia patients, they don't want to be in the ER for 8 hours just to get blood work done or to be told we don't have anything else to offer you. And the caregivers definitely are upset when they come see me and they're like, we were in the ER for like 6 hours. Um, and the reason is you don't have chest pain, you didn't have a stroke, you didn't have syncope, you're not bleeding out of your orifices. So you're not going to be seen right away. You're going to be seen like down the line because you're stable. So that's how insurance coverage, works between Team Blue and Team Orange. Um, this might be feel free to clarify the question. I'm just going to try to answer as best I can. So another example is a hospital bed. Some of my patients, I mean, they're awake and alive and talking and recognizing their families, but their body is tired. They have peripheral neuropathy from their diabetes, or they have osteoarthritis and they can't walk really well. So they're kind of having range of motion and physical limitations. So the family will say, "Hey, can we get a hospital bed?" So if you're on Team Blue, I have to write the prescription. I have to describe why you need the hospital bed. And then I hope that your insurance will provide you with a hospital bed at zero cost or at very little cost. I don't get to control that. Sometimes it shows up really fast. Sometimes it's a lot of money. Sometimes it takes forever to get the hospital bed. All right, so that's Team Blue. Team Orange, if you wanted a hospital bed, it would already be there because the moment that you enroll in hospice, they will bring all the stuff that you need for that comfort care end of life transition, whether it's 6 months, 8 months, 6 weeks, 6 days. You will get your hospital bed. You will get your comfort care kit. You'll get your oxygen tanks. Some would say that they bring too much stuff and we don't even need it, but they're bringing it so that you have stuff in your toolbox in the event you need to use it in the middle of the night or the middle of the day, and you don't want to go to the ER, you don't want to go to the hospital. That's why they give you all this stuff. So I think I'm going to stop there. I mean, I could go on forever, but if there's a specific clarifying question about that, I can.
There is actually.
Okay.
So we've talked about Team Blue and we've talked about Team Orange,
Mhm.
but somewhere in the middle is palliative care. And how does insurance deal with palliative care?
Very simple. I'm a specialist. So I'm not, um, I get kind of like triggered when people say, this patient is on palliative care. There's no such thing as on palliative care. Like you're on hospice because it's a program, but you're not on palliative care, just like you're not on pulmonology, you're not on oncology or neurology or cardiology. You see a pulmonologist, you see your neurologist, you see your palliative care physician. So as a specialist, I am paid as a specialist. It's an office visit. There isn't this like membership or nurses coming to your house or some sort of like package deal. It's like you have a physician specializing in this part of medicine. So that's
That's
why I'm
a
under the specialist
great
team.
answer. Yeah, great answer. Um, I have another question. Mom-in-law is currently one of your patients. She's 92 with dementia. We're getting very concerned about her mobility. She's fallen without injury, but if she falls and go to the ED, do I have them notify your office at that point? How
It
does that work?
depends. Yeah, it depends. I don't control Epic and I don't control other people's workflows. I believe that the common workflow is that the primary care team will get a message that your patient's in the ER. I sometimes get those messages, but I want to say it's like 5% of the time. And I really don't know who turned that on or who turned it off. Um, I get alerted that my patient's in the hospital if the family will call me and say, I just want to let you know mom's in the hospital. Sometimes my MA will be going through whatever she's going through in the chart, and she'll see that the patient's in the hospital, so she'll let me know. Other times I find out is if the hospital is taking care of your mom, feels that it's important that I be involved, or that they're like, hey, we're gonna talk to Mrs. Pham's family about surgery for this broken hip. I just want to know what insights you have because I'm meeting her for the first time. And so they know that I have seen this patient one time, two times, more times than they have. And so they're like, hey, Lynda, what insights do you have before I go talk to them? This will help me help them. So that's how I get notified. Other times, which is again rare, I would expect this to be more. Um, if the family or the patient is in the hospital and they're not getting what they need and no one's listening to them and they're like, I'm supposed to get this medication and you're not supposed to do this and I don't want to go to this rehab center, or I've told them I don't want this. Like if the team is unresponsive or not talking to you, or the medical team isn't getting you, not that you're not getting them, but the opposite, I will get like a tattletale kind of phone call from the family. They're like, our needs are not met. These doctors aren't listening to us. This is what, we agreed on. So then I will pick up the phone and call the hospital team and work it out and advocate on your behalf, whatever that may be. Or it might be that you get on the phone and you're like venting and screaming, and then I have a chance to calm you down and say, this is what's really going on. I'm really sorry that they're not explaining it to you, but this is what I see in the chart. This is what the doctors have told me. And then sometimes that is better because those families usually have developed a relationship with me and they trust my interpretation of what's happening. And it could just be that, you're stressed out, you're in the hospital, you don't know if your loved one is going to make it. You don't know what this means when they come home. You're nervous about it. Or maybe you feel like it's too soon for them to discharge my mom. Like I don't think she's ready to go home. There's just so much stuff going on. And I found that when they call, I can usually like de-escalate, or I can like kind of tease some things out. Sometimes it's just, here's the short-term things you have to do, which is get through the hospitalization, get out of the hospital. And then the medium to long term, you're going to meet with me. We're going to talk about what happened in the hospital, and we're going to come up with a plan for what to do next. Sometimes it's literally just I have to clear the air and just organize it, because when you're in the hospital, I just feel like things can get really overwhelming.
So we have one more question about insurance and rules, and that is if my loved one is in a facility, do the same rules and care and insurance apply? And that is referring to palliative care and hospice.
Yeah. Um, whether it's hospice or palmed, we don't care where you live. I think there's documentation that if you're seeing palliative medicine or any of your doctors and you're in a skilled nursing facility, we have to document that you're living there, but it doesn't change the care that we give you. That's more just on the insurance end of it. But I've never had to worry about seeing a patient because I'm not the one counting the beans, okay? I'm just there from, 8 until 5 to see my patients. I'm not the one that's like worried about whether or not I get paid. And it's never been an issue for me to see somebody who needs to be seen. And if I can't see that person, it's really not my control that I can't see them. It's some other bigger thing um, than me or you or the patient. But yeah, we're just team blue. So the insurance doesn't really like, they literally just see us as another specialist. And I've
Okay.
never had, if anything, I've had insurances say to me, will you please see this patient for us because no one else has referred? And we're looking at the the file of the patient, and they could really use palliative care. And this is not them calling the family and getting some sort of intel. It's like they're looking at it, they see all the chronic diseases, they've seen the burden of readmissions, and they're like, why hasn't palliative care been consulted? We will pay for all the specialists, but the very specialist that you need, you didn't even like refer to. So I'll get those phone calls.
Okay. So we have a question here that kind of goes along with the questions that we discussed before. And the question that is in the chat is what exactly qualifies a dementia patient for hospice care? The question that we discussed was when can a care partner anticipate that end of life is approaching and that hospice is appropriate? So, same question in different terms.
Yeah, that's a really good question. So let me go from like easiest to more complex. Um, if I don't think having dementia is easy by any means, and I'm going to take off my doctor hat for a minute. As a human being, if I had dementia, I would be devastated. I believe that it's one of the harder diseases to have. Um, and that's just me as a human being talking to you that that's my thing. Like, kill me in other ways, but please don't give me dementia. And I don't mean to offend anybody here, but I just wanted to make sure that having easy dementia isn't easy. Okay. So putting the doctor hat back on. If you don't have any other disease except dementia, then this is how it works. Let me show you. Okay. This is
Yes.
called the functional assessment scale. And dementia is categorized on 7 levels. And this is just a very easy way for me, for you, to look at. So you might just start asking the questions. You don't have any difficulty, then your functional assessment scale is 1. Now you're forgetting stuff. Maybe you're having trouble at work. So it goes down the list. Once you get to like 6 and 7, then there's subcategories below it. So I would say most of my patients are already in the 6, 5, and sometimes 7. I hardly have somebody who is 2, 3, or 4. So you have to kind of go through those lines, but once you get to 6 and 7, it doesn't actually go in order. So for example, you might not have urinary incontinence or fecal incontinence, but your ability to speak is winding down. So then you're 7A, but you're not 6D or E yet, but it's going to be around the corner. In order to black and white on a piece of paper, go to hospice, you have to reach 7C, C as in cat, meaning your ambulatory ability is lost. You can't walk without being assisted. You would have gone through everything 1 up to that point. You would be incontinent of urine and fecal. Your talking would be limited to less than 6 words per day or the single use of a word. You can't put on clothes properly. You need so much help. So on paper, if you walked into my office and you said, I wonder if we're ready for hospice and if hospice will take me, I have to first check if you have gotten to 7C. If you come in and you're not at 7C, and I would say like a very small percentage of my patients are like at 7C when I send them to hospice. Let's say you come in and you're 6B or 6C, but you have heart failure, COPD, cancer, you got something else, and it is attacking your life and it's causing you to go to the hospital over and over again. You would be going to hospice under the COPD or the congestive heart failure diagnosis, not the dementia diagnosis. But if having those comorbid chronic diseases has made the dementia worse, and has caused a tragic decline in a short amount of time. We're talking like a month, 3 months, 6 months, right? Tragic decline, as in you're losing the ability to get out of bed, you're not eating as well, you're losing weight, sleeping more, just kind of like withdrawing, and it's rapid in like 3 to 6 months. Hospice will say, we don't care what stage you are. We think in the next 3 to 6 months, you're going to die. So that's when you go to hospice on a conditional basis with a diagnosis of dementia, and they will watch you for like a month, and they will see if the decline is continuing or if you're going to be too healthy. Because in that month, if you're too healthy, they will graduate you back to Team Blue and say, when you get closer to death, then come back to orange. But in that month, if you're continuing to show signs that you're heading towards, the waterfall, then they will continue to service you under Team Orange. Questions about that?
I think that's really appropriate because I just had someone this week tell me that suddenly her husband was, or hospice wanted to discharge her husband related to a 2 pound weight gain after an extensive weight loss. And of course, he was admitted to hospice based on a wasting diagnosis, not based on a dementia diagnosis. So, but it's a complicated thing when people have come to rely on hospice and suddenly it's pulled out from under them.
Yeah, I think sometimes patients, no, not patients, but families will come in and they will say, we want hospice. And maybe what they're really asking for is home health, or they're asking for caregiving. They're asking for more help, not necessarily comfort-based end of life transition help. And so, as a specialist, I have to be able to determine what exactly it is that they're asking for, or else they're not going to the right place to get what they need. And this might be helpful. Here we go. So this is in picture what I said in words. So you have time at the bottom, you're familiar with that. And then you have function on the y-axis, right? Low function, high function. Dementia is this like grass is growing, dwindling, frailty. It just is slow compared to like cancer or other diseases where it has like highs and lows and like um staircase decline. Dementia kind of goes up, it kind of goes down, it like levels out a little bit, and then it just drags on over time. And I think this is why dementia is probably one of the harder diseases for families and caregivers and people who you call family. Like it's so much harder for the caregiver. Yes, your body is not going through dementia as the patient, but it's one of those diseases that you see every day. You see it every minute, every hour, every day. It's in your face. Whereas cancer, it's inside of you. Like you might see, weight loss. You might not even see that that patient has cancer at all. But dementia is this constant disease reminder. And I think that's why Hope Dementia Support, and all these other community offerings is so much more valuable to the family because you have to take care of them so that they can feel strong and equipped and supported to take care of the patient who has dementia. And possibly that's why I think like it's for me personally as a human, it's one of the harder diseases to grasp and to accept if I were, to have dementia. Because I just think it hits different.
So once dementia is diagnosed, is it too late to complete an advance directive?
I would say that depending on the stage, right? Before you get to dementia, you have this pre-dementia diagnosis of mild cognitive impairment, MCI. Um, I feel like I have MCI, right? I don't know where my keys are and like can't tell you what happened last night. But you have the MCI, and then you enter into mild, moderate, severe dementia. So what's important for advanced care planning is it actually should start at 18 years old. Um, it should start, there's these like 5 Ds. I'm always going to get this wrong, but advanced care planning needs to happen. Uh, death, death in the family, death of somebody you know, makes you think about mortality. Start talking about advanced care planning. Divorce, things are being shuffled. If you're legally divorced, um, then that absolves the other person of being the spouse and then being your representative. If you're divorcing but not on paper, you need to clear that up right away because under the law, if you were in a car accident, your spouse would be next. And if your spouse happens to be your ex, I'm not sure that they would make decisions in your best interest necessarily. So death, divorce, disability. So if you lose some sort of function, then you really want to talk about your advanced care planning. Disease. So if you get a new diagnosis of a disease, it might make you think. So for example, your new diagnosis that you have chronic kidney disease and you are heading towards dialysis, you probably should start talking about some advanced care planning with your family, with your power of attorney. Um, so decade. Yeah, that's the one that I always forget. Every
Okay.
10 years, if nothing else happens, you should be looking at your advance because every 10 years, you're kind of like, was this still true for me? Right? Because things that were important to me at 18 are differently important to me at 28, 38, 48, and so on. So every 10 years, you're like, let's review this. I do have a sort of schematic for it. So here. It's going to be this one. Okay. I'm going to walk you through this. Oops. Okay. So this is again, you're going to be seeing this like line a lot, right? This age, time, disease progression. So this is talking about like the stages of your life and decision making based on your quality of life. And so if you were going to look at the beginning of this, I would say that this is 18 years old because legally at 18, lots of things are available to you. And that's when you can decide and designate a power of attorney for medical decision making, right? Everybody drives. Mostly everybody drives. And if you don't drive, you could still be in an accident. So good to have a power of attorney designated. So this yellow thing is saying that let's say you end up having some sort of disease that over time pulls your function down. So we can say that that is heart failure. Well, in the beginning of your 18 years of life, you want to be thinking of just basic advanced care planning, right? Adults, you're healthy. You might have a little hypertension, but by no means anything is going to go crazy, except for a car accident or some act of Mount St. Helens. So at that time, you want to name and prepare a healthcare agent. And it starts at 18, but this basicness can go all the way until dementia or death because you just have to look at yourself. You need to look within yourself. Do you have a DPOA on file right now? And that'll tell you, like, oh, I'm 45, I'm 50, I still don't have one. So anytime from 18 and onward, that's why the yellow arrow is like ongoing advanced care planning. You should name a healthcare agent. Ideally, 2 to 3 names, right? Because what if you're driving with that one that is your number one? You probably want a number two and a number three. Then over time, your illness might get a little bit more challenging. complications, hospitalizations, more medications, seeing the specialist more, then that's when you really want to start having like a serious illness conversation with the doctor, with the attending, to be like, where is my diabetes going? Oh, but my kidneys are now affected because of my diabetes, and now my heart's affected, and now I have neuropathy. So kind of like fleshing it out and be like, do you really understand how severe your chronic disease is? So that's called the goals of care. And then when you're in your last 2 years of life, or 1 to last 2 years of life, then that's when you actually should fill out the POLS form, which is the physician order for life-sustaining treatment, otherwise known as the bright neon green do not resuscitate form. Yes, the form is being signed inappropriately in the community. Like you go into the hospital, they'll just throw the form at you. That's actually not what the law was written for, but I'm fighting that battle every day, like trying to educate clinicians on how to use the form correctly. It was intended for the last 1 to 2 years of life. And so you should be filling that out. And it goes over like CPR, feeding tubes, ICU, life prolonging things. So, my last statement, maybe if you get nothing else out of this talk, advanced care planning is not paper. Advanced care planning is a process with people over time. That's where Washington State has been heading since 2015. You see the Respecting Choices logo down there. We have something called Honoring Choices, and it's the paradigm shift that the United States is heading towards. Why? I can't ever find a piece of paper when I'm in the hospital. I have family members who have their important documents in the bank safe. That's not available to the doctor when they're taking care of your chest pain or if you're having an accident. The paper is like almost never where it's supposed to be, but the people are. You can always pick up the phone to call the people to find out what the planning conversations were and then be able to provide the care and respect people's choices.
So step back with a dementia diagnosis. I went to the doctor today. I was diagnosed with dementia. Do I still have the ability to determine what my advanced care planning choices are?
Yeah, you do. Um, I'm a hair splitter, so take what you want from me, and if it's like all fluff, like you'll hear me next year. So, I think of advanced care planning um as my stories to my family. My stories such as I love coloring. I love writing in my journal. I love playing cards. I love cooking. I love spending time with my grandkids and visiting them in California, which means I have to get on a plane, right? So I think of advanced care planning as these stories about my quality of life, to which are hints and clues to my family about what my line in the sand is. You can have those stories be true for you as a dementia patient. You can have those stories true for you at 18 years old, which then those stories will change as you age. If the dementia patient still has those true stories that are consistent over the course of their life, the family can take that to the bank because that's not the dementia clouding any of those care preferences. If the patient has dementia in a way that they say something like, I would love to live as a vegetable for the rest of my life so long as somebody will come and visit me. And you're like, that doesn't really match up with how you have spoken through your whole life, then you can't trust that statement, right? It's like if you have 30 days of life And one day is a happy day, and the other 29 days is like vomiting, chemo, tiredness, ER visits. Your 30 days is not happy. Your 30 days is bad. Your quality of life is bad. Don't focus on that one day that's good. So same thing with these stories, right? Um, on a granular legal, medical, ethical, legal viewpoint, as a physician, if I come to you as a dementia patient and I need to do a procedure, let's say I need to do a catheter, to look at your heart because you had chest pain. So I'm going to do this like angiogram. If I came to you and said, "Do you understand what we're about to do? Can you tell me in your own words what this angiogram is going to be?" And you, Lynn, could answer my question, then I'm like, okay, this patient has capacity to understand the procedure. My next question would be, Lynn, if we don't do this angiogram for you, what will happen to you? Like, if you refuse this angiogram, what will happen to you? And if you're able to tell me in your own words, well, my heart disease could get worse. I don't know what disease it will be. If you don't do this angiogram, I could die because if there's a blockage, then you have answered the questions for that specific decision making, right? So that's called like capacity. If I can get you to answer questions, capacity is like specific to the question or specific to the treatment, then you have been giving me your shared decision making. You will still have capacity to answer the question about angiograms. You may not have the capacity to balance your checkbook. You may not have the capacity to buy and sell your home. So that's where the hair splits a little bit. So what I tell people is it's never too late. You just have to make sure that the family is around and can get the puzzle pieces and say, is this a puzzle piece that actually fits the board? Or is this some little one-off thing that she's saying and it's actually not rooted in reality? That's how it gets tricky. And that's why we want people to do this upstream starting at 18. We do not want you to have a stroke layered on top of a little bit of dementia, and now you're depressed. And now you're so depressed that you don't want to even think about going to rehab. You don't want to go to physical therapy. Woe is me. So then suddenly you're like, well, we're not sure. Like, what should we do? If you had pneumonia, should we go back to the hospital? Should we not treat it? What if you broke an ankle? Should we do surgery on that? So then it gets a little bit tricky later on. And then it gets even more tricky if your family is very black and white about, and I shouldn't use that word, if they're very like polarizing in terms of hearing your wishes. So here's an example. I had a patient who had an accident, not dementia, right? Had some other type of cancer that was seeing me, but then they had a tragic accident. So let's just say a truck hit them. They were in a coma, and the family could feel that the patient could blink their eyes, could squeeze their hands, but otherwise was just in bed, not eating, fed through a tube, no communication, just opening the eyes, tracking a little bit, squeezing hands. And to the rest of the medical community, we're like, we think it's time for end of life transition. And the family's words to me were, it's not that easy. If only he was clear about what he wanted, we would make a decision. But the fact that we can't even ask him right now, we just can't. So that went on for about 3 to 4 months.
Well,
So that's not even dementia. That's
mhm,
that's something else, but you can see how it's adjacent to all of this.
exactly.
And they were very bound by honoring their loved one's wishes. And they're like, because he never said anything to us, we can't live with making this decision for him.
Couple of other sideline questions. Does insurance cover home health under specific circumstances?
The only requirement for home health is that there is a skilled need. I think of home health as a beginning and an end. Home health is very specific. You need wound care, there's a beginning and an end. You need physical therapy, there's a beginning and an end. You need antibiotic support in the home because of IV infusions, whatnot, beginning, end. That's what home health is. Caregiving, which often gets confused with home health, caregiving is I need somebody to come in, babysit, help me clean up the house, sit with me, help me take my medications. That's just caregiving, and it can be anytime for as long as you can afford it and whatever you can cover. But home health, as long as there's a skilled need, we make physicians will make a referral and insurance pays for it. That's why the nursing home or skilled facility stay has a certain number of days before they kick you out because it's a skilled need. And once that skilled need is met, you must go home. You must go to somewhere else.
Is it legal for caregiving agencies to require a pulse if a patient is somewhat stable and not close to that last 2 years of life?
So I think legal is that really weird operative word. Can they require it because it's their policy? Sure, they can require whatever they want. And then you, as the consumer, is like, well, if I want to go here so bad, I'm going to play by their rules and whatever it is that they ask of me just to get in through the door. Um, was the pulse written that way to be used that way? No. Absolutely not. That was not the intention of the form or the order. The pulse form is an order set, right? It's not an advance directive and it's not a living will. It has its own little like weird area. It's actually an order, just like I write an order for like antibiotics or a script. This is an order. An order is if this person is not breathing, no heartbeat. The order is do this or do this. Um, the only difference with that order is it's the only order out there that a patient or caregiver signs in addition to the medical practitioner. So it has its own little category. But yeah, it's they're not going to go to jail for making you sign a post. And if you feel so strongly that you're just signing it for courtesy, check full code because the boxes aren't do not resuscitate. It's do not resuscitate, full code, full treatment, selective treatment, comfort-based care. So that's where I
Well,
sit with that.
I do think that an important thing to consider is if there's been pretty serious conversations about what someone's wishes are, and that we know that without a pulse that says DNR, that paramedics will do everything that they possibly can do to resuscitate because they're required by law to do so.
So I talked to the paramedics about this, and I talked to the ICU doctor about this. So this is anecdotal, but I think appropriate. Okay, so this is what happens with the paramedics. They show up because the caregiving home, adult family home, caregiving agency, whatever, calls 911. They get there. They look at the refrigerator. The refrigerator says, "Do not resuscitate." I would say 50% of them are going to be like, okay, well, the form says do not resuscitate, so I'm not going to do it. Let's say there is a daughter or family member that happens to be there when this happened. And if the daughter said, oh, we had a conversation last night. My mom wants this reversed, and I'm the POA. As an EMT, I could either say, I will take this form and go to court with it and I'll win. Or I just listen to the person yelling at me. I mean, it's human, right? They're yelling at me. They're saying, like, I'm the POA. I'm the one making medical decisions. You must resuscitate my mom, either or. So that's why papers are pointless. Planning, conversations, and people much more proactive, much more succinct. So then there's no question of what the paper says if you find it. and then what the patient really, really wants. Same thing in the hospital. This actually happened to one of our doctors, ICU doctor, had the pulse said do not resuscitate. Patient was in the ICU, not intubated, and then was having fevers and getting close to intubation. The daughter's like, you have to intubate my mom. And the
Yeah.
doctor said, well, I I hear you. And I also know that she signed this with me. And so we really should honor, she signed it, not you, right? Like we should really honor that she was thoughtful about this. She was in her right state of mind. She was not under distress. And so I feel it's our obligation to honor this. So he pushed back and the daughter kind of was upset. Luckily, the mom made it and was seen by me in outpatient. But the daughter reflected on that and said, wow, he pushed back. I didn't like it. But then now that she's better, I realized that those feelings are true. Those feelings. So that's why when you select your power of attorney, make sure you pick the right person. And usually, what I advise patients is if I were blindfolded and I was taking care of you in the hospital, whoever you choose to talk to me should sound exactly like you, that I could not tell the difference. That's who your power of attorney should be.
I love that. So, my mom has had dementia for 10 years and is now at a level 6D on the functional assessment scale. What is the longest amount of time that you've seen this slow moving illness go on?
So, it depends on like what's surrounding it. If it were only dementia, um, you could just look at her changes, her delta, right? So, what happened in the last 3 months, that got her to 60? Has she been at 60 in the last 3 months? Okay, she'll probably stay there for the next 3 months. It's going to go as slow as it has been going. It goes faster if you got to 60 pretty fast. Then the next interval of time, it's going to go just as fast. The context being, are there other things hastening the dementia? Things that hasten dementia or hospitalizations. Um, Two examples. One example is I don't look like I have dementia at all. I haven't, I'm aging. I'm like 80 years old. I'm forgetful and I'm kind of slow, but I don't look and behave like I have dementia. Suddenly I have a UTI. I'm dehydrated. It's hot outside. I go into the hospital. Well, the hospital is a strange place. Beeps, clicks, smells, people. Suddenly I have delirium in the hospital. Then they fix my dehydration, they fix my UTI. I get better. I go home. And now the daughter's like, her cognitive function changed dramatically as a result of that hospitalization. So in that example, the hospitalization uncorked, unmasked the dementia that was always underneath. It was just slowly moving. But then because of the hospitalization and the frailty and the functional loss that hospitalization caused, it just opened everything and things just came out. So if you have a bunch of those hospitalizations, you're going to move past 60 a little bit faster than if it's only dementia harming you. So I'm going to show you a picture that might help. All right, so I showed you this first one, which was just regular, dementia. And the next one is that functional loss, right? So if you happen to have COPD, heart failure, diabetes, some other disease that's causing you to go into the hospital and out of the hospital, you can see how that costs you function, right? The dips are hospital admissions, right? Because you're functionally going to be lower because you need to go to the hospital for pneumonia or maybe a heart attack or an exacerbation. And then once you get treated, you're going to go upwards in this slope, right? You're trying to rehab. That's why they send you to skilled nursing facility. They try to like get you better. And then you continue to decline because of the dementia, because the natural disease declines. But it goes faster if you keep on having these little valleys. And that's why the line goes like this. Now, if you were to superimpose this red line with this red line, that's how you find your truth of how fast you're moving through dementia. And sometimes it's not the actual memory loss, it's the burden of the disease on the memory loss. The other thing is how dementia, hurts you is you wander into traffic, you leave the stove on, you mix up your medications and you take them inappropriately. So there's other things that are trying to kill you while you have dementia. So I like to think of it as like, yes, dementia is a disease. I feel like how you die from it is usually opportunistic, right? So if you're in bed, you can't move very much, you're incontinent, then you're up for like UTIs, you're up for bed sores, you're up for aspiration pneumonia, um, any number of those things. It takes advantage while you have dementia.
There's a question about Washington's death with dignity. Why does it not apply to people with severe dementia who no longer wish to suffer the cruelty and ravages of dementia, but are very physically healthy?
Um, because of the workflow, they need to have capacity to answer those questions. Do you know what it is that you're asking for? Do you know the consequence of what you're asking for? So that informed consent, they can't answer those questions. That's number one. Number two, they have to have a terminal diagnosis of less than 6 months in order to call forth death with dignity. Number three, depending on how severe their dementia is, they actually have to be able to hold the medicine and take it themselves. Nobody can give it to them. Nobody can feed it to them. They have to be able to be upright and take it themselves. So there's many different hurdles and gates to pass before you actually get the prescription and medication in your hand. So for dementia, if it is towards the decision-making capacity, you can't even get through all the steps because the steps are you have to verbally ask your right to do it. Then you have to formally write it down as a request. Then you have to make a second verbal request, and then be evaluated by two clinicians, yada, yada. And then you get your prescription. That's why.
So addressing the pulse a little bit, those specific questions that are kind of brought up. The first one, is CPR appropriate in dementia?
I would say that it depends on it depends on a lot of things. So when I think of CPR, there's two types of CPR or two settings. On the pulse form, the first setting is something happened that cut off your breathing and cut off your heart. It could have been a car accident, it could have been a stroke, a heart attack. It Something killed you. So in that first box, the question is, do you want to be given a chance to wake up? Do you want the CPR? So I would say that if you are 65, otherwise really healthy, have a little dementia, no heart disease, no lung disease, you probably should be resuscitated if you want to. You have a better chance of coming back than somebody who is 65 with heart disease, lung cancer, frailty, losing weight, has cancer, because it takes an act of God or what you believe in to bring back something that died, right? If your heart stopped and your lungs have stopped, you need something electrical, drug-based, physical maneuver to pump that heart back and bring you back. The part where I come in my consultation is, what are you coming back to? Because if something killed you and we brought you back, you don't just walk out of the hospital. You don't get up from the mall and then go home. Like that's just not how that works at 65 and older, unless you are a unicorn. There's not a lot of unicorns out there. So the question is, what are you coming back to? If you're coming back to being on a ventilator and you have dementia and you're not going to get off the ventilator, why did you do that? And especially if you told your family, I don't want to live on a ventilator. I don't want to be in a vegetative state. Why did you do that? Because now we've done it. Now your family's going to have to turn it off. So I think that is a burden on the family. I think that we shouldn't start things that require other people to stop for us. So that's one scenario. The other scenario is if you have disease burden and CPR is not going to have any chance of bringing you back to a meaningful state of life and quality of life, then your advanced directive and your quality of life stories have already answered that question that if I'm gone, don't bring me back. Don't kill me twice, right? If I'm dead, let me remain dead. Make sure I'm comfortable. Make sure I'm really dead. But don't bring me back only then to kill me again by withdrawing support because my quality of life is not so great. And that quality of life is so different for everybody. That's why this advanced care planning over time is so important. Because for some people, they're like, if you bring me back and I don't get to go home, I would be so sad. I would be so devastated. I'd be so depressed. If you bring me back and I could still recognize my family and I could sit in a wheelchair and still enjoy, you know, hikes and walks with the family, that's okay. Walking is not that important to me. Driving is not that important to me, as long as I recognize people. So you have to ask, what's the likelihood of the success of CPR? So you can't really say like, is dementia appropriate? I like to think of it as, what do I have right now? And the chances of me recovering to a meaningful state of function, that's whether or not I need to decide if I want CPR or not. And then you put it into the context of what other diseases are going to frame the success of CPR. The second box on the pulse is a little bit more nuanced because it starts off with you breathing and having a heartbeat, but something is happening on the horizon, such as pneumonia or UTI or dehydration, or maybe a little chest pain, but you start off with a heartbeat and a lung breathing. So then the question is, if you start going south, do you want us to kind of pull you back so that you don't end up without a heartbeat and no breathing? So that's where the full selective and then comfort base. That's why those three boxes are split up in section two. I hope that was thorough enough or
I
just
thought
enough.
that was perfect. So the next question is related to the fact that very frequently people with dementia as their dementia advances develop issues with swallowing. And so what is your thoughts as a palliative care practitioner about placing a feeding tube in someone who is aspirating and will continue to do so if they eat?
Um, you can still aspirate with a feeding tube, right? Because there's stuff going into the stomach. Aspiration is the idea of like things that go down go back up, and then they go into the windpipe, and then they go to the lungs, and then aspiration pneumonia also is very fast. Other types of pneumonia might show up a couple of days later. Aspiration pneumonia is the fastest developing pneumonia. It's about 24 hours. Like you'll get sick. 24, 48, but about 24. So when I think of a feeding tube, I think of it as like a tool and a bridge. And I also think of it as a beginning and an end. So if someone has a car accident, they're in the ICU, they have a stroke, they have surgery, there's a beginning and end to that feeding tube. It's to bridge you through the recovery phase. It's not meant to be lifelong. And that's how I would like it to be. And so if the situation is very clear that this is a temporary bridge so that you can go back to eating, because I expect you to recover, then it's appropriate. Going back to feeding tube, I align that with intubation. It's a form of life support. If you're going to start something and then later have to stop it, is withholding better than withdrawing? Because under the law, withholding and withdrawing is the same. Emotionally, it's not. Deferring treatment versus stopping treatment emotionally feels different depending on the person choosing it, depending on the power of attorney that is choosing it, or the family caregiver or family that comes together that has to make that decision. Feeding twos become emotional annoyances at the end of life and pathological annoyances. When you're at end of life in the last hours, weeks, days, months, the feeding tube is a source of extra fluid burden on the body. It is no longer really helping. It turns into um, more burden. Because if my kidneys are shutting down naturally, if my heart is starting to shut down, my lungs are starting to shut down, and I'm feeding it work, which is the feeding tube, the fluid, the proteins, then I am asking my heart to continue working, my lungs to continue working, my kidneys to continue working, and they're ready to shut down. So now you're actually making it worse on the body's natural process. And so what happens to that fluid is it turns into edema. You swell. You might have trouble breathing. The fluid that would have been cleaned out by your kidneys is now getting into your lungs. There's a rattle that comes with some of that. But basically, you are hydrating somebody to keep them alive. The body can live purely on hydration, even if there's no food. But if you stop hydration, the body will die, even if you feed it. So hydration is probably the part of the feeding tube that is like artificially keeping somebody alive. Um, so there's these nuances with feeding tubes in terms of starting them, stopping them, leaving them on for a long time. I think it still goes back to what is the quality of life? What is the goal? That's why it's called goals of care. Like, why are we doing this? So there's a loophole in all of that. And this is also where palliative medicine comes in. I might ask somebody and say, Lynn, I know your advanced directives say that you never want a feeding tube. I wonder if there is something short term that you need to get to. It is May. We're almost into June. Is there a graduation you need to be around for? Is there a wedding coming up? Is there another child that needs to be born? Do you need to go to another trip? I could use that feeding tube to bridge you to that really important goal that you have to witness. And then I would say after that, you can discontinue the feeding tube. That's a loophole. That's a gray area. That should only be used on that offering should only be used under like specialist advice. I would never teach somebody to say that to you because it defeats the idea of like um quality of life when we offer long-term feeding tubes for people who are approaching the sunset. The other thing that might be helpful to the audience is that at end of life, days, hours, weeks, maybe short months, people do not have hunger. And so we as family, caregivers, friends, family are like, oh my God, you're starving. You haven't eaten for a week. We know what that feels like because we're not dying. But the person that is getting ready to die in transition, they don't feel hunger. So not feeding them isn't this injurious, cruel thing. If anything, it's merciful because you don't want them to aspirate. You don't want them to die that way. You don't want to be the cause of more burden. And during that time, under really good hospice care, they will advise the family, hey, um, the person dying might want the texture and feel of ice cream in their mouth. They might enjoy that. You can give them that. But at that point, you're not eating for survival and sustenance. You're eating for joy. You're eating for comfort. Once again, I hope I answered that question.
You absolutely answered that question. So, okay, last scenario. My husband has dementia. He's had it for some time. With his dementia, he has frequent episodes of aspiration. He has frequent urinary tract infections. What do you think about antibiotics in that scenario?
Um, I think that um, if his if you're not under hospice and you want longevity of life, possibly quality of life, that falls under treatment. That falls under cure. How effective it is depends on what um, antibiotic resistance he has developed. But the idea of giving someone antibiotics is I'm getting rid of that disease. I'm getting rid of that infection so that you can get better, so that your dementia doesn't get worse, so that you don't land in the hospital with sepsis, right? Infection, not so good. Sepsis, really not so good, because then that's like ICU level. That's like serious. So if the antibiotics can afford prolongation of life and maintenance of quality of life, go for it. If he's being treated and it's working, but it's not working good enough that he's going in and out of the hospital every week, every month, it seems like he lives at the hospital more than he lives at home. You have to ask, what is his quality of life? What is the goal? And again, the goal could be graduation, wedding, anniversary. The goal could just be, I'm okay. I don't mind going to the hospital so long as I get through it. Something is going to crack for you, for him, in terms of the quality of life. When you're like, we can't do this anymore. We don't want to do this anymore. Or it's not working anymore. The antibiotics are actually not working anymore, and there's more harm than good in seeking treatment and cure. And then to an extreme, if the medical community, doctors, nurses, teams are like, there's no more antibiotics. We refuse to give any more because it's not going to work or it's going to kill his kidneys or whatever reason, right? Doctors and practitioners have the right to refuse care. Um, Patients have the right to accept or refuse. They don't have the right to demand a certain type of surgery, treatment, medication. Doctors have the right to do the right thing. They also have the right to say, no, I am not going to do that because it would hurt you, it would harm you, it would kill you, etc. So that's going to come off as like very legal, very inhumane, but that keeps us all honest in terms of like our expectations. It manages our expectations better.
Okay. One more question, and then we are just about done unless other people have something coming. And that is it usually better for a palliative care physician to manage meds due to symptom management? My mom has four prescribing physicians.
Yeah, it depends. The vanity is when patients come to me and say, could you be my primary care? Um, and I would say that I can't because I'm a specialist. You know, your pulmonologist is not your primary care. Your pulmonologist is a specialist. Um, it depends. I think like when patients come to see me, if their heart drugs, lung drugs, whatever drugs are prescribed by their primary, it stays there because those changes and those nuances stay with the person who manages it. And then I am more than happy to manage any symptom drugs that will help with breathing or sleeping. But my drugs don't cure you. My drugs don't make the disease different. My drugs help you face the disease and treat the symptom that's going to come with the disease because the disease is taking its course. So the goals of the drugs are different. Um, I would say that if you have four different prescribers, and you're able to get in with PalMed or talk with your primary to kind of corral it to two, you could negotiate that. But once again, going back to what physicians can and cannot do or will and won't do, if there's a drug that they're not familiar with or they're not comfortable prescribing, they're going to ask you to go to that specialist to continue prescribing that drug for you. But everything else is fair game, right? Um, Primary care can manage hypertension, diabetes, COPD, heart failure. They can manage a lot of things. It's when it gets into funny land that they really want their referring specialist to manage those drugs.
Awesome. 3 minutes. I have a couple of thank yous. Thank you. We learned a lot. We're in year 9 of the
Yeah.
dementia. This has been immensely helpful and informative as my husband is presently on hospice and was recently discharged from the hospital with pneumonia and a severe UTI. He's now getting all of his care through hospice rather than his PCP and specialist.
hmm Yeah.
So,
Lynn and I were
so
gonna do a little role play with that, but this is a good example of that. Like what does it look like if you call Blue Team at 3 a.m.? What does it sound like if you call Orange Team at 3 a.m. for the same exact chief complaint? Yeah.
so helpful. Would you mind providing me the few slides that you use so that I can just send them out with people?
Yeah, absolutely. Probably more than you want.
Well, that's okay. I'll do it.
Yeah.
So we appreciate it so much. Thank you, Lynda.
Yeah,
Um,
thanks for spending the evening with me.
well, if we had another couple of hours, we could talk about some of the horrible experiences that some of our folks have had recently related to end of life and 27 days in the hospital without being able to sit with your agitated husband, only to have him die after being on hospice for 2 days. Um, things like that. But I think the things that you have shared will be helpful to everyone. So thanks for taking your time.
No problem. We hope that these talks move people's minds upstream. Um, I think I'm just like a disaster averse, chaos averse. Maybe I'm a control freak and I just want things to go well. So I entered palliative medicine and just to give people resources and tools to just normalize the conversation, ask people what their quality of life is. You don't have to talk about death and dying. Just ask, what's a really good day for you? And what can't you not stand to lose? And some people say driving. Some people say their sight. Some people say their home. A lot of people don't want to leave their homes. So yeah, start early, often, and then you'll find your way home much easier once you have a more colorful map.
Somebody has commented that your nuances were immensely valuable, not just this or that. She loved the discussions with the nuances. So thank you
Oh,
for.
thank you.
And
All right,
somebody else
so
asked why you wanted to be a palliative care physician. I think you just answered that question.
yeah, that's a personal OCD, like recovering perfectionist. But I think the deeper story is there was a lot of puzzle pieces that um, the world, the universe, God, whoever's up there, like put in front of me, and those pieces came together. And then PalMed fit that piece. So that's how it came together. I couldn't tell you 20 years ago that this is where I would be. No way.
Oh, I'm sure not. Yeah. All right. Thank you so much.
All right.
Thank everybody for being here.
Thank you so much.